Dr. Kranti, she has not joined, no?
No, I cannot see him.
We are live now.
Yeah, start the
Doctor,
music, Dr. Nehi.
Just a minute, just a minute.
Yeah. Shall we start?
No, ma'am. Just a minute. Yes, you can start, ma'am.
Yeah. Yeah. Good evening, Dr. Kranti. Yeah, she has joined. The speaker has also joined. Welcome to this interesting webinar arranged by Raigad IIP, AHA Maharashtra, AHA Raigad, and Palghar Academy of Pediatrics on the occasion of Antibiotic Awareness Week. Shall we continue, Dr. Neha? Shall we continue, Dr. Neha? Any issues?
No,
yeah. So we are in 21st century where our up-to-date is replaced by ChatGPT and Perplexity. We have to be future ready. And the immense desire to be walking with tandem with ever-changing scenario of our microbes. In this process of learning and relearning, we are aware about various functions of billions of organisms sitting inside our body, our gut microbiota. With preservatives, chemicals, changing lifestyles, changing food choices of our young generation, we have to be very much miserly in using the antibiotics. So in this antibiotic awareness week, we have chosen topics which are near to our heart and can be useful in our day-to-day practice. The adolescent care physician and pediatrician is the torch bearer of future generation. And to tell in detail about the welcome and the dignitaries, may I invite Raigad IIP star member and Secretary Raigad AHA, Dr. Neha Singh.
Thank you, ma'am. Good evening, all the respected dignitaries on the dais. Ma'am has already introduced the topic what we are celebrating, Antibiotic Awareness Week and Day. So I request Dr. Vikas More sir to give his invite speech and welcome all the dignitaries. Over to you, sir.
Good evening, all. It is my great honor to welcome you all to this very important CME organized by IIP Raigad, AHA Raigad, IIP Palghar, and Maharashtra Adolescent Health Academy. Tonight, we gather not only to sharpen our clinical skills, but to refresh our wisdom on antibiotic stewardship. Because we all know the antibiotic, which I take antibiotic as one guest at a party, is very useful if invited properly, but troublesome if they overstay. So treat it just like a guest in a party. So our first topic is to explore the delicate art of using the antibiotics, prescribing them or where not to prescribe them in our tiniest patients. Those are infants and toddlers. After all, they can't exactly tell us when the ear aches or when something happens to them because they can't express them. So sometimes what happens if their cry is so loud, कुछ तो उनको दे दो. So in that hurry, we see a lot of unnecessary use of antibiotics in this particular age group. Dr. Amol Jaive is a trusted expert in the pediatric infectious disease in Navi Mumbai, and will definitely guide us through all this. Now, then we'll focus on the adolescents and those very trickier gynecological situations. And I know that the pediatricians, as such, are not much aware regarding these typical situations and how to actually prescribe the antibiotic in these particular situations. So we are very fortunate to have Dr. Kranti Fadnes. She will share her insights on this. So as a pediatrician or a healthcare providers, we sometimes assume the role of a detective or a teacher or even a magician sort of to convince the parents that really the antibiotic is not necessary in this particular phase. So let us engage very actively in this session, ask more questions, absorb this knowledge, and let's get together so that reduce the length of our prescription and give the best treatment to our little childrens. Thank you so much. Over to you, Neha. And before I end, I am really thankful to Dr. Sangeeta Loda Madam and all senior dignitaries, and especially special thanks to Dr. Amol Zainbe and Dr. Kranti Fadnis for giving their valuable time for this particular session. And especially the IIP Palghar branch and Maha AHE. They have always been very eager to work with us in all these noble initiatives. Over to you, Dr. Neil.
Thank you, sir. So today's program is Raigad IP with IP Palghar, and with Maha AHA and AHA Raigad we are conducting this program. So I would like to welcome Dr. Sangeeta Loda ma'am, who is Secretary Maha AHA. Over to you, ma'am.
Yeah. Thank you, first of all, for inviting me for this prestigious talk on the Day of Antibiotic Awareness. And I'm so delighted to be a part of this session today. And the topic well chosen by you is really that. Where to prescribe and when to avoid, and then second one is the judicious use of antibiotic in adolescents. You are very true, because antibiotic is prescription is an art, and that too right antibiotic with right dose with right duration and to the right patient. And being pediatrician, as the patients are from the very beginning with us, so when they become adolescent, then they are very much open to their pediatricians. So when they come with their gynecological problem during their adolescent age, we must be aware of when to use these antibiotics and when not to use. So I think the overall session will go very nice, as the speakers today are very well known and stalwart speakers, and the topic also given to them is a worth to be chosen for them. So my best wishes to you, and thanks once again for inviting me.
Thank you so much, ma'am.
Yeah.
Now I invite Raigad IIP Senior Pediatrician Dr. Mahesh Mohite sir to say a few words. Over to you, sir.
Thank you, Neha. Thank you, Dr. Chitra Kulkarni Madam, Vikas More, Sanjay Kanoda Madam. Thank you very much for this opportunity. I thought I'll be talking after the initial talks on academic things, but wonderful. This is an amazing initiative. I think we are already into deep into the stewardship program on antibiotics. In fact, the stewardship program extends to many other topics also. But for last almost a decade, we have been discussing about antibiotic stewardship to reduce the use of antibiotics, because number of available antibiotics and effective antibiotics in clinical practice is gradually reducing because of the extensive use of antibiotics, not only in human beings, but also in the animal husbandry. In fact, there are multiple reasons why we are facing this monster of antibiotic resistance. I'm sure Dr. Amol and Dr. Kranti Pandit Madam will be addressing to that. And it's the best way of sort of sensitizing our friends, our juniors, all our colleagues to use a less number of antibiotics, be focused, be precise, give us narrow spectrum antibiotics when essential, and de-escalate as early as possible. So many things are there in that stewardship program. I'm sure my friend Dr. Amol and Dr. Kranti will be addressing to that. Thank you again, once again, for inviting me for that. It's really an interesting topic. Thank you.
Thank you, sir, for your blessings. Now I would like to invite Dr. Vikas More sir again to introduce our speakers, both our speakers of today. Vikas sir.
This is Dr. Kranti.
Vikas
Yeah.
sir.
So, shall I start?
Yes, ma'am, you can introduce, please.
Yeah, we are very fortunate to have Dr. Amol Jaibhai as our first speaker today, and he is from CMC Vellore, the prestigious institute, and he is very sincere and hardworking, practicing in Navi Mumbai area, and also attached to SRCC Children Hospital, Mumbai, Jupiter, Surya Children Hospital, and CTC and BMT Centers, Borivali. Young ID Fellow in 2018, and he is having a travel award ASPID 2018. He is having 7 publications in index journals, 4 original articles, 3 book chapters, 2 IAP guidelines, and he is interested in transplant medicine, tropical infections, critical care, and antimicrobial stewardship, and our savior, our general pediatrician savior in Navi Mumbai area. Welcome, Dr. Amol. A
Thank you,
second
ma'am.
speaker is Dr. Kranti Fadnis. She is associate professor in NMMC as well as MGM Hospital CBD Belapur, a thorough clinician, very popular obstetrician, and she is interested in adolescent health, high risk pregnancy, psychological counseling, menopausal issues, and fertility guidance. We are very fortunate to have such eminent and popular gynecologist as our speaker today. First, may I request Dr. Amol to start his deliberation.
Yeah, good evening, everyone. Uh, so today I am going to talk about the rational use of antibiotics in infants and toddlers. I will give a superficial idea and the basic knowledge of like when to prescribe, where to prescribe, which drug to prescribe, and when to de-escalate also. So my objectives are like, next slide. We will see like define like rational use of antibiotics, followed by like identify when to prescribe antibiotics in infants and toddlers, then recognize when to avoid antibiotics, learn recommended durations, and understand the importance of preventing the resistance. I will give some first talk what is basically a antimicrobial stewardship. So in antimicrobial stewardship, we use antibiotics only when it is necessary and it is required. We will choose the right drug, dose, and duration according to your bug or bacteria identified in the culture or the throat swab. We sometimes get isolate viruses. We will prefer narrow spectrum agent when possible to avoid the misuse and the resistance of that antibiotics. Okay. So basic principles are like in infants and toddlers when you basically choose antibiotic. So basically when you confirm any bacterial infection before prescribing, if you have isolated staphylococcus aureus or streptococcus in blood culture, if patient is presenting with a infant or toddlers presenting with a high grade fever, with signs of meningitis, and you have sent the blood culture as well as you have done the CSF and you have isolated any organism like streptococcal meningitis, then this is the indication where you will after suspecting antibiotics, after suspecting an infection according to the symptoms, you will start empirically children on antibiotics. Then once you have isolated the bug on the blood culture, you will get the blood sensitivity reports and culture sensitivity report, and depending upon that you can narrow down your antibiotics. So like what is the MIC of that drug and whether it is sensitive. According to that, you choose your antibiotic and try to give like a needed then only single antibiotic. And there are certain conditions where we use a dual antibiotic if needed, but as possible as I will suggest to give a single antibiotic. Then avoid antibiotics for viral illnesses. So this is the most area where the most of the our patients in pediatrics age group, they present with a URTI, and we commonly see that most of the time the URTI will not require any antibiotic at all. So where the most of the antibiotics has been used in for the respiratory use. So whenever you are using antibiotic, you should use basically the weight-based doses, milligram per kg, and do not use overdose, and do not also use the underdose, because they will work with that particular concentration. They will achieve the blood levels, and that is like minimum inhibitory concentration of the antibiotic that will kill the bacteria and it will eradicate the infection from the blood. Nowadays, there are multiple studies which have shown the shorter is the better version of the antibiotics. Means they have studied like for some gram-negative infection, if we give 7 days of antibiotic instead of 14 days of antibiotics, which previously using, has not changed anything, or it is not an inferior trial. But those all studies are done in a Western scenario. So currently to our Indian setup, whether to apply or not, we have to say according to our own study. And then at the end, we should educate parents and regarding the compliance of the medications and this thing. So next we will give some few indications like when we prescribe next slide please. When we prescribe antibiotics in infants and toddlers, so there are certain indications like bacterial pneumonia when the child present in a this thing. So when you diagnose it, means when the child, depending upon the, there are classification of pneumonia like mild, moderate and severe according to the respiratory rate. So depending upon that, we will see, and if we have isolated anything in the throat swab like a deep bowel culture, then we can give antibiotics. Then for urinary tract infection, it is recommended to give antibiotics. Streptococcal throat infection after confirmation of the diagnosis, and then severe otitis media in children, some skin infection like impetigo and cellulitis, and life-threatening infections like meningitis and sepsis, where there is an absolute indication of a antibiotic in infant and the toddlers. Okay, so next slide. So when to avoid antibiotics? So as I said, like most of the time, the respiratory illnesses like upper respiratory tract infection, common cold, viral cough, bronchiolitis, where there is no use of antibiotics, and it adding antibiotic will not help to improve the condition of the patients. Then second, most of the sore throats, like where those are mostly will resolve within 3 to 4 days, which will also need not to give antibiotics. Most of the times you will see the viral exanthemas where the child will present with a fever with rash like measles, chicken pox, roseola. So in that scenario also you don't need to give antibiotics to the all children unless and until there is a secondary infection causing pneumonia. Then only you can give in these patients antibiotics. Viral diarrhea also is where you have to just manage the patient on only ORS and oral zinc and the other supportive measures. So I will show you the chart. Next slide. So condition wise, like where you need antibiotics and the minimum duration of antibiotics to be prescribed. So in common cold, you will, next slide. So in common cold, like URTI, as I said, or pharyngitis, most of the time it is viral, so you don't need to give an antibiotic. Otitis media, in a mild condition, you don't need to give antibiotics, but otitis media is severe and less than 2 year, where you have a chances of a hearing loss or the ear damage, where you need to give antibiotics, and the minimum duration will be like a 7 to 10 days. Like streptococcal pharyngitis or sore throat, where you need to give antibiotics, that is for the 10 days. Okay. uh, then next slide. In pneumonia, when the pneumonia is non-severe, you can give shorter duration of antibiotics. Severe pneumonia, depending upon the organism which you have isolated, you have to give antibiotics. So these chart I have prepared from the WHO book may not be apt, but these are the basic guidelines which where the antibiotics has been used. Your antibiotics has been chosen according to your actually your every institute have their own antibiogram. So like throughout the year or in the last 1 2 or 3 years, how many isolates you got from blood culture, respiratory, and other cultures, and according to that you will see the sensitivity pattern of that bacteria in your hospital or ICU, and you can use according to your antibiogram, which is most of the time it is hospital wise. So we see the all the guidelines where they say that this is the basic guidelines. So these are for like you from the primary healthcare structure, secondary healthcare structure, but certain hospitals like tertiary healthcare center, where the patient will not be always a naive patient. The patient will come in a complicated form. So these antibiotics will not be applied at that time. Okay, so if you see the neonatal sepsis, you need to give antibiotic. Meningitis, you need to give antibiotics. Acute diarrhea, as I said, we can manage by giving ORS and the zinc. Then the dysentery, when there is a blood in the stool, then you can give antibiotics. And like enteric fever, you can give the antibiotics. These are the short summary of the infections or this thing where we can give antibiotics in infants and toddlers. Most of the time, if you see the not every fever will need antibiotics. So you have to evaluate the patient. You have to take the thoroughly history of the patient. You have to see like what symptoms, signs, and presentation of the child is there. And according to that, you can take a call and decide whether to give antibiotics. And most of the illnesses like upper respiratory tract illnesses are viral illnesses where you don't need the antibiotics. So as I said, shorter courses work for many conditions. You can use avoid misuse to prevent the resistance, and rational prescribing saves lives and the preserves the antibiotics. So the nowadays, if you see, the WHO is also emphasizing more on antimicrobial stewardship. If you use more antibiotics in your hospital or in your practice, over a period of time, the those bacteria are also very smart, and they have a different mechanism like target modification, enzyme inactivation, reduce uptake, or efflux mechanism. By that mechanism, they will inactivate the antibiotics with the different mechanism, and they will get modified themselves. Those bacteria will get modified, and you cannot treat those basic infection if you start giving antibiotics for where it is not needed. So you, as Mohite sir earlier said, the antibiotic has been used widely in other industries like poultry and all that. So you can see the like they will give to increase the weight of the hen and all that, they will give the colistin granules, and you will see the abnormal size hens, and they just want to increase the size of the meat and all that. But over a period of these things, like even you don't have anything in your hand, but people are using abusing in other industries also. And yeah, the fertilizers, if you use, you can see the modified genetics of the new weeds and the seeds they are using. So that is causing more problem in the community and the society. So at our level, I will suggest like if you have a proven infection, then only you use antibiotics. avoid using antibiotics unnecessarily when there is a upper URTI or the common cold or the any viral infection. Uh, that's it I want to say on this.
Thank you, Dr. Amol. And we are having very experienced and talented co-faculty as an expert today. Over to Dr. Mahesh Mohite sir for his comments.
No, I'm not an expert. When Amol, ID expert like Amol is speaking, I'm not an expert. I'm just going to give you whatever I have earned over last 30 years or 35 years of practice. So I think the biggest challenge that I've seen amongst the pediatrician is to differentiate between virus and bacteria in a clinical practice. And I'm sure that is there for ages. And more you become senior, probably more it confuses because occasionally you're failed in labeling something as virus and rarely you might have been troubled by not giving antibiotics. But believe me, I'm sure Amol also will agree that you need to be bold at certain situations, right? He gave few situations wherein there's just throat pain or kind of a rhinorrhea, multisystem presentation. Definitely, you confirm it is very likely virus and you don't have to do anything. When you're in doubt, in fact, nowadays for an indoor patient, we have that PCR being available to confirm various viruses. In fact, presently we're going through a huge epidemic of influenza and RSV. And most of our patients are without any antibiotics being treated with only symptomatic line of treatment. The first challenge is to call, confirm, and label virus as a virus. Once you do that, write it on paper. Obviously, you will not earn on the side of writing antibiotics. Second, lot of point of care ultrasound, a point of care bedside tests are available. A throat swab for streptococcal antigen, which is extremely reliable test, almost sensitivity and specificity of more than 80%. And that can be used when you're in doubt whether it's bacterial or viral pharyngitis. So if it is virus, obviously you won't be giving antibiotic. If it is bacterial, Amal has already mentioned amoxicillin for 10 days. That's a good idea. UTI, again, just because there are pus cells in the urine, don't start antibiotic. You send a culture and you can do your nitrates and bedside test to confirm your infection. If that is strongly positive, you will start antibiotic. If it is not positive, then wait for the culture. What I meant to say, there are so many things by which you can first differentiate whether it is bacterial or viral. If it is viral, don't give antibiotics. Second challenge in the practice is we are always worried, we give justification that there is super added infection and due to which I started antibiotic. So note, evidence clearly states, yes, influenza can get super added, but RSV is rarely to get a super added infection. So don't justify giving antibiotic in those kind of scenarios. Only condition where my threshold for giving antibiotic is low when the child is less than 6 months, yes, I won't be taking chances not to give antibiotic. When the child is severe PM, yes, he is immunocompromised, and of course, all other immunocompromised, where you may be justified in giving antibiotic upfront. But otherwise, there is a reason. Even statistics says, even in the neonate and early infantile age group, highest chances of infection is still virus, almost 60 to 70% or maybe more. And after about 1 year, 90% of your infections are virus in a community practice. So it's good idea. It's one of our friend, Amol, you also may be named Dr. Panniraman from
Yes, sir.
Chennai, from
Chennai,
Tamil
Chennai.
Nadu. He maintains his audit, and in one of the meetings, he published audit of almost 3 lakh patient prescription. He said only 6% patient required antibiotic in the OPD, 94% are without antibiotic. I think that's what we need to aim. We need to revise our own kind of numbers and see where we are erring on antibiotic and try and stopping them. So that's all I had to say. Thank you very much.
Do you want me to take the question simultaneously or
Yes.
Sir,
you will be
now we will go for the second presentation and we will do all the questions later on. We are having enough time. Shall I ask our second speaker, Dr. Kranti Fadnis, to take over? Not yet seen. Yeah, you start your presentation, start your screen sharing if possible.
At the outset, I would like to thank Dr. Chitra Kulkarni ma'am for the opportunity. My heartfelt gratitude to all senior pediatricians. I can see Dr. Mohite sir and all Mahan people of this Maha CME webinar here. I have just made a small Google form and I've posted in the chat box if you can just fill it in the meantime that I share my presentation. Is my
Yeah.
Is it visible?
Yeah, it is visible. Make full screen. Yeah. Yes. And I'm happy to share that Dr. Kranti is now head of the department of NMMC. Congratulations.
Thank you, ma'am. Thank you for the kind introduction. Starting with this, in the meanwhile, that you can just fill the forms. It is only a 5-point questionnaire with pictures as to make us aware which conditions require, which do not require, and maybe types. So today's topic was judicious use of antibiotics in adolescent pelvic conditions, as was told by ma'am, because ma'am is very keen on adolescent focus, and so am I. Today's contents would be common issues in adolescence, vaginal discharge, a couple of cases I would discuss, common symptoms of underlying conditions, what are the common conditions we encounter like acne, folliculitis, tinea cruris, acanthosis nigricans, douching, foreign body in the vagina, healthy practices that we can ask our adolescent girls to follow, educating the adolescents, and algorithmic approach towards these conditions. The common adolescent gynecological issues in the OPD, a few of them are unavoidable, like white vaginal discharge, which is physiological, cyclic breast tenderness, which is physiological, ovarian cysts, which keep coming and going, pain during periods, which is supposed to be going to regress after one childbirth. Some of them are avoidable, like pelvic infections. Once a girl is sexually active, then is the source of infection, or sometimes there is candid infection when there is moisture retention. Trauma during use of tampon, some of them are using tampons and now it is being replaced by menstrual cup as well. Fingering or self-stimulation during masturbation, and some of them are both. So acne, excess hair growth, bulky painful breast, small lumps in breast, and napkin rash, most of them are associated with overweight or obesity. The white vaginal discharge is common and mostly it is very difficult to counsel, but most of the patients it is physiological and we have to counsel that it is not a pathology, as I commonly say that when after menopause you would complain of dryness, so you should be happy with the mild wetness that's there. Occasionally it can be associated with fungal infection, which is the classic curdy white discharge, and we have to all of us are known what type of the fungal curdy white discharge comes with. If patient is sexually active, definitely the diagnosis will be varied. Bacterial vaginosis, mixed vaginitis, cervicitis, pelvic inflammatory disease, all of these require to be inspected and then only we can diagnose the condition. Commonly we come across with washes now that are advertisements and social media awareness, and all of these intimal washes destroy the Dodderlines bacilli. So whenever there is an opportunity, we should make an attempt to talk about these washes and demotivate our girls to use just these washes which are replacing water and soap. Use of sex toys or menstrual cups. Sometimes girls often forget the menstrual cup inside. Sometimes there is a cervical erosion, Nabothian cysts, vaginitis, and cervicitis because of these girls which are not sexually active, but because of the tampons and menstrual cup insertions, they have kind of lost the virginity and started experimenting with fingering and insertion, which is quite painful. Sometimes, of course, the force and POSCO is not our topic of today. Iatrogenic like use of dilators in those conditions which are of primary amenorrhea, and we have to advise the patient MRKHS, and conditions where of primary amenorrhea sometimes due to secondary to COX, where we put in a copper T so as to cause the menstrual function to retain. Just one simple case, a 10-year-old girl brought by her mother. She's complaining of itching in private parts and there is no foul play suspected. So what would be our common differential diagnosis in this case? It is very essential to build a rapport, and the girl on her own, she should come out with the complaints that she frequently uses water when she douches the area, and then typically moisture retention causes moist panties, and then once we respect her and once we are able to connect with her, then behind the curtain we can actually ask if there was foul or if there was force, or sometimes it was mutual consensual in a little elder girl also. So the consent, connect, concern and checking will help us to correlate and come to a diagnosis. Most often it is candid infection and it has to be treated with local application wherein we can't insert a pessary as the hymen is intact. Which are these conditions which are quite confusing? So these are like genital herpes simplex. There is quite an overlap with dermat conditions and gynac. Sometimes we are very confused and we often refer to the dermatologist just to get a feedback. I call them back, but it is total under the purview of dermatologist, the genital warts, molluscum, and the herpes simplex. Unless the dermatologist is not available only for symptomatic treatment about the pain, burning, and the itching part, we would consider. But entirely following up with a dermatologist is what I follow. This tinea cruris or tinea corporis is classical with its margins and the delineated itching, and often the rash extends to the perianal region. So that ringworm infestation, we have to counsel the patients to maintain separation of separately wash, and hygiene has to be maintained. If they are sexually active, the partner also can get infected. And so that distance has to be maintained till complete cure of at least 14 days. A long treatment is required. There is no treatment required if there is no itching. The white discharge has to be counseled that if there is no itching, no rash, no foul odor, and it is not mixed with blood, then this is absolutely physiological. So wherein the role of reassurance, allaying the anxiety, which goes a long way, because we have had patients who opted for hysterectomy because of the white discharge, and it is quite shocking. Then counseling about the physiological and pathological discharge, hygiene, basically to cut the nails short, keep the area dry, frequently changing the undergarments when it is moist, avoid the washes when it is so much of peer supported and peer advertisement also. So resistant to use the washes, and the opportunity to connect the patient towards HPV vaccination, and of course safe sex. It's no longer abstinence, it is safety now. Acne, the treatment differs depending upon the severity, symptoms, spread, and the syndrome. Syndrome is polycystic ovarian syndrome, wherein we see many of the young girls with when there is tendency to gain weight. We are not holding them responsible, but then the tendency to gain weight is quite demotivating them when they come to losing weight, and that is also the reason for hirsutism and acne. And we have to focus on weight reduction as an essential part besides the cosmetic hygiene, all this, but weight reduction goes a long way. Folliculitis, when there is use of razor or epilating cream or trimmer or different types of hair removal like plucking, waxing, and the only solution is to be very careful and avoid these. If there is a tendency, of course we have to check the blood sugar levels, and some of that skin is sensitive to moisture, sweat, friction, and there has to be dryness maintained in such cases. So we have to give oral antibiotics if there is a follicle and an abscess which is under formation. Tinea cruris, we just discussed that tinea cruris or ringworm is common in areas which are susceptible to moisture, like the gluteal folds, also inframammary, as we are seeing in the picture. And generally the girls they are hesitant to come out with the complaints. We have to ask leading questions, or kahin pe hai, or kahin pe hai, and then they come out, and maybe sometimes it is there, the mothers also may be having, or maybe in the family how it is transmitted, and it has to be treated with oral itraconazole as well as antihistamine, the main symptomatic treatment, and the topical application of miconazole gel for a prolonged period. Acanthosis nigricans, the black marking due to which is essential a hallmark of insulin resistance and polycystic ovarian syndrome. The skin is thickened and there is nothing to be done about it. It is more of a cosmetic concern. and we have to counsel and take that opportunity of counseling them to lose weight. Almost all the patients, I keep telling lose weight, and so douching is something which is now more. I learn more from the patients because the social media awareness is much more in them, and the different pictures they come out with and the pleasure they get. Sometimes it is due to fear, it is due to hygiene, and some many misconceptions that the odor has to be removed off and whatnot. So there are some scented perfumes also, there are some douching techniques also, and that they experiment and the teenagers come out with new complaints. It certainly disrupts the vaginal flora and increases and spreads the infection because the borderline bacilli will be dislodged. And regularly washing with soap and water is all that we advise. Douching is the process of flushing out if there is infection, if there is a trigger, like suppose there is a copper T insertion or there is frequent intercourse, or um, uh, young woman, girl with multiple partners, then we have to counsel again about a pessary inserted timely, besides the fact that a single partner and motivation with barrier contraceptive. But essentially douching is not what we advise. Foreign body inserted and left in the vagina, sometimes it is accidental, sometimes it is deliberate. Toilet paper is the most common which is seen, a tampon which is forgotten, a menstrual cup is forgotten. Even in reproductive age group women, forget the adolescent girls. And then sometimes it's difficult to remove. I have had patients who have come later on with a discharge, a foul smell, fever, a low grade fever. And then when we check, oh, I forgot the menstrual cup. So this was some 15 days back that she had finished her menses and continued to have spotting and foul smell. And this was, of course, not in the adolescent girls, but it might be later on. So toilet paper was found to be the commonest. Opportunity to educate. This is a window period that we get to educate them about vaccination, hygiene tips, safety measures, because Google is the only teacher for them nowadays, and they would first of all not come openly to a gynec. Once they have come, don't lose the opportunity, or even a pediatrician. Once we connect with them, they open on their own and then confess that they have been using eye pill or over the counter antibiotics, and we should advise them about against the pills for cycle postponement also. That is something I commonly tell them. So the practices which are best should be followed, like simple things like cutting the nails, cotton panties, keeping the area dry, frequently changing, and safe sex. Best avoided are do not douche, vaginal washes, eye pill. Vaginal discharge, as we said, is common after periods due to the sensitivity of the skin. The skin is very tender, and the napkins are no matter how many they change, the plastic coated ones, and there is a lot of advertisement, and cottony dry is supposed to be better, smaller size better, extra large, all have their own schools of thought, but commonly that's a trigger for allergy and prolonged moisture that will cause itching. So we have to give them a break. Sometimes I do advise them the old timing, like the orthodox cloth use, karo, maintain hygiene. Sometimes cotton panties, cotton napkins which we use after delivery, so those have essentially only cotton and no other synthetic material. So keep the area, we should take care of the delicate skin, and we have to ensure there is no foul odor and ask for practices what they have been, whether there is douching or whether there is masturbation. There is no role of antibiotics for painful periods. Allergic rash, where we just advise an antihistamine. Sometimes coconut oil does wonders. Nepotian cysts, ovarian cysts, these will come and go. They are not supposed to be infected unless the girl is sexually active. Heavy periods, of course, there is no role of antibiotics. Acanthosis nigricans, honeymoon cystitis, very frequently in young girls because of the short urethra. Just alkalizer does the work. Fibroadenoma breast, there is no role of antibiotics. And of course, torch infections, widely misused antibiotics. Once they have got the infection, they are permanently resistant to it. So just an algorithmic approach to summarize. Once the patient comes with vaginal discharge or lesions, ensure whether she is sexually active or sexually not active. If she is sexually active, then it could be by force, it could be by choice, and then our treatment changes. Medical legal intimation, it starts with that. Sexually active, if she is not sexually active, we have to communicate with her such that build confidence, ensure privacy when we check up, and she opens up and she tells all the proper history. That is all we want. And after inspection, we come to know what type of discharge is there. There is evidence of any hair removal which they have resorted to, if they have experimented some new wash, or whether there is some insertion of sex toy or something. And dermat reference, at times we should not hesitate. They are a common friends. And medical legal notification in POSCO cases. I thank you all for a patient hearing.
Thank you. Very crisp and to the point presentation. Here we do get adolescent girls having different type of problems, and you have covered most of them.
Thank
May
you,
I
ma'am.
request Dr. Mahesh Mohite sir to give his comments on this topic as well as his critical care experience for the adolescent girls.
Uh, First of all, let me confess and declare that I'm not an adolescent expert. I am a general pediatrician and what a little bit of part of the general pediatric OPD adolescents I see. But yes, there are few critical care issues and there are few things I'll just quickly go through. So what I realized from Madam Kranti Fadli's talk is most of the issues are mainly because of unhygienic practices. And that's because of the misinformation the adolescents get through Google and now ChatGPT. And the age-old guides, the mother, the grandmother, are getting the backseat and the front seat is Google and ChatGPT. So how we can promote that get back to the old days and the family system, I suppose all those problems were not that great. And nowadays we do see kind of these exclusive examples. Second, you talked about critical issues. Yes, those tampon-related toxic shock syndrome. I have seen few cases coming very bad and very critical because of toxic shock syndrome. That's a simple strep or staph infection, but yes, at times they can be life-threatening. So they should be made to understand those seriousness and get in touch with a critical care expert for the emergency ICU management. Few points I definitely want to stress here is compulsion of taking HPV vaccine in the next generation. I think with a changing kind of a society and social system, HPV vaccine should be really very aggressively promoted. Every adolescent girl should be given HPV vaccine between the age of 9 to 45 according to the various vaccine they are validated for different age groups. And nowadays that vaccine is also validated or kind of recommended for adolescent boy as well, not only in the girl, because there could be cross infection and olden days of HPV4 has gone. Now we are talking about Nona vaccine, wherein we are almost having 95 to 100% kind of coverage of the virus. So aggressively promote HPV vaccine. And last but not the least, our society is going the Western way. Don't underestimate that hidden monster of sexual abuse in the family, in the neighborhood. And most of those things are, I think, what you notice is hardly few percent of what is really happening. So we should be very careful about our young generation, the bad touch, good touch, and all those things which adolescent chapter has been doing so well over the years. That should be really taken, and that should be first of all. I think we need to train the mothers to train their children right from the early age group because this sexual abuse thing is really increasing very aggressively. We need to be very careful about this. Those are my inputs from this talk. Thank you very much again for giving this opportunity. Thank you very much.
So just I want to say something regarding HPV vaccination, sir. I'm very much proud to say that last year I have given 13,550 HPV Cervavac vaccine, quadrivalent vaccine in Nasik, Malegaon, and Satana. And this year my target is to give 20,000 HPV vaccine, and we are including Gardasil as well.
Oh,
So
okay.
in 23rd, 24th, 25th, I'm going to Prayagraj for giving 1,500 vaccines. And then after that, I'm going to Haridwar, Rishikesh, and Roorkee for giving 2,000 vaccines. So,
Mhm.
with the help of CPAA, we are providing this vaccine to
Sure, ma'am.
underprivileged girls between the age group of 9 to actually target group is 18 years. And we are using single dose according to the WHO norms
WHO.
for mass vaccination. So this is really
Amazing.
very proud for me
Absolutely
to
amazing.
share with you all.
Definitely.
Absolutely amazing.
Uh,
Yes.
It's like somebody takes a life mission. You have taken a life mission.
yes, yes,
Congratulations and
yes,
thank you for that.
yeah.
Excellent work. Excellent work. Yes.
It's very nice and heartening to hear it from you, Dr. Sangeeta. We are very proud of you that you are doing such a noble work. And may
Yes, sir.
I invite Dr. Jayashree Deshpande, President, Palghar Academy of Pediatrics. She has just joined to give her comments. Dr. Jayashree, please.
Congratulations, Sangeeta madam, and I am really happy and proud to be associated with you for many things. And this is a very important vaccine which we should promote for boys and girls as well. And even for the elderly ladies till the age of 45, we should advise this 9-valent vaccine which is now available. Thank you so much.
Thank you. Shall we go for question answers now? Dr. Ram Bharat had asked one question. Dr. Ram, are you there? You can ask
Yes, madam.
directly. Yeah, yeah.
Good evening. Good evening, everyone. And very nice and insightful talk by both the speakers. I just want to ask, when we were doing residency in Nair, at that time we used to give antibiotic to babies born with meconium stained amniotic fluid. And at that time the concept we had learned was the babies are little bit suffocated, asphyxiated. At the same time, this meconium fluid, even though it is sterile, but it can act as a good source for, it can act as a good culture media for various bacteria. So we have to give prophylactic antibiotic. So what's current stand on a baby with meconium stained amniotic fluid?
Dr. Amol?
Uh, so generally we don't prefer to give antibiotic because most of the time, as he sir said, most of the time the meconium stain babies are like the meconium itself is not an infected. So the routine use of prophylactic antibiotics is not recommended if you see the guidelines. So only the if the child is having any clinical features of sepsis or respiratory distress, fever, lethargy, because meconium stain also sometimes have this, but transient tachypnea and all that will get settled within 1 to 2 hours. So unless and until there are risk factor like prolonged rupture of membranes or maternal fever or like foul smelling liquor or chorioamnitis, then it is prudent to go ahead with the antibiotics. Otherwise, there are no any recommendations for like every meconium stain baby should get antibiotic.
Sir,
Okay. Mohit
and
sir?
in a
Yeah,
and
I was just
if
saying
there
that
is, yes, sir.
why, yeah, yeah, just 1 minute. So basically, why people are using antibiotic in such scenario on day one or day two itself in this meconium aspiration, people do obviously hemogram, CBC, CRP, but invariably you will see the CRP being high, 30, 40, 50. And based on that, they start. That's what is my experience in most of the centers and most of the places. Meconium baby itself basically passes meconium because he's stressed baby in the perinatal period during the labor process. And that stress itself induces all stress inflammatory markers and CRP being one of them. So if you see, take all those 100 patients of meconium, almost 95% of them will be having CRP high. So alone CRP high is not a marker of infection at all. We need to learn about this. And if there is no other evidence, say PROM or any maternal infection or any obvious signs of infection, just because of CRP is high, don't give antibiotic. I've seen that's the commonest reason why people use antibiotic, and that's absolutely wrong reason to use antibiotic in a meconium strain like that. Okay.
Sir, and what about if there is premature rupture of membrane or leaking PV? What we had read in between 18 to 24 hours. If there is leaking PV from 18 to 24 hours, then there is probable risk of infection to baby. But if it is more than 24 hours, then there is definite risk of infection to baby. So if some mother comes from a rural place on some multiple vehicles, bail gadi, and in very bad condition, badly handled, and if that mother is born and there is history of leaking since 48 hours, the baby is not sick, but still shall we give that baby antibiotic?
Amol, you want to take it?
Sir, you take it. I don't do more
Okay.
of a neonatal
Okay.
practice. So
Okay.
yeah, yeah.
Yeah, Dr. Ram, I'll tell you the reason why people they recommend not to give is in a way these guidelines have come from predominantly Western world. So there are no home deliveries, there is no bullock cart transport, there is no other rural transport. And if there is a leak of say 48 hours, this mother is admitted and immediately installed antibiotic antenatally. And we assume or presume that the antibiotic has already started working within next 48 hours. That's the reason why perhaps they don't give it in the guideline. But yes, any leak more than 12 to 18 hours. Now, why 12 to 18 hours? It's a statistical significant time they have found out. So I have extreme preterm babies, which is born with a leak of 4 or 6 hours. Do I don't give antibiotic? Actually, in Indian scenario, we don't have a system to check the placenta. In the Western world, they will do definitely placental examination, placental biopsy, placental histopath to find out if there is any chorioamnitis. So if there is a chorioamnitis, then in that case, even without a leak, one would give complete antibiotic and do all the infection screens. So the scenario which you mentioned, if there is a leak beyond 24 hours or say 48 hours or 72 hours, yes, in an Indian scenario, we have to give antibiotic to this patient. Obviously, before giving antibiotic, make it a point to collect a set of blood culture. When I say set of blood
Yes, sir.
culture, at least two samples of blood culture, which will be at least 0.5 neonate. Usually, they are polybacterial growth. You require a relatively smaller sample, so 0.5 ml in each of it. Now, if you have a finance issue, then you can collect 1 or 2 ml in one single and still send it because it's ultimately the volume of blood which is important rather than number of
Yes, sir.
bottles. So set of sample. Any baby, a preterm baby delivered with the PRI more than 12 hours, we definitely send the cultures, we send all the parameters and start antibiotic upfront. So that important thing is
Yes, sir.
collect the samples appropriate for the scenario and then start antibiotic. Don't start empirical antibiotic without having because at the end, first 12 or 24 hours, your basic inflammatory parameters and all hemograms are normal. And after 3 days, if the blood culture is normal, make it a point to de-escalate or stop the antibiotic. That is equally important. The why the antibiotic stewardship program fails in Indian scenario is there is no de-escalation policy which is followed aggressively by most of the units. Amol, do you agree with me? We are very
Yes,
champions
sir.
in starting, but we are not champions in stopping it. That's a big problem.
Yes,
Yes,
sir.
sir. So de-escalation, most of the time people has a fear of, that is only the thing, like it's only fear. That's why we are not de-escalating. But in our hospital, we are having a antibiotic stewardship forms. We give the reason why to stop and why it should not be continuing. So we do the assessment at every 48 hours. The blood cultures comes negative, we will stop. Even in a febrile neutropenia like patients, we try to de-escalate once there is a no fever or fever escalate. We will give for like 72 to 96 hours and then we will stop.
Yes, very
Thank you,
nice
sir. Thank you.
inputs. Any question for Dr. Kranti?
Madam, painful and inflamed thilarchy, starting with unilateral breast. Is it indication for antibiotic? Because it's painful, inflamed, and girl is troubled with that.
The anti-inflammatory, yes, not antibiotic.
Okay.
And in case
Yeah,
there is sometimes means we have to educate her that it is the marking the onset of menarche. 6 months down the line, she'll be having periods. So start educating and counseling her about safe touch as well, and then breast support gradually.
Thank you. Thank you.
Yeah, my question is that, Dr. Kranti, nowadays we are seeing early adolescent girls having injury to vulva because of toilet shower, and many of the times there is a secondary infection as well. So, means is it indicated that we have to give full course of the antibiotics with that?
Ma'am, I think if the mucosa is disrupted, then we should be giving. But if we are counseling them about clipping their nails, the nails have to be flat for, because during daytime and all of them have that fantasy of long nails once they are out of the
Oh,
school.
yes.
So if they even if they are trying to do it with the palm and the phalanges also, but when they're sleeping they will be scratching with long nails accidentally, and then that results in superadded infection bacterial. So then those cases we have to give, and it goes to like oral, because folliculitis will not heal with topical. So counsel them that it is best to avoid, and just gentle the speed of the shower sometimes when they're, which floor they stay on. So that way the height of the building matters, and that way the jet spray also is very fast sometimes. So that will cause,
Yes.
sometimes may rupture the hymen as well. So if it's very light and just sometimes for coconut oil does wonders. So coconut oil and antihistamine, that is sufficient. If there is breach of the mucosa, then we have to give antibiotics.
Yes. Thank you very much. Thanks for the guidelines. Any other question, or shall we wind up?
Thank you, ma'am. Thank you, everyone.
Thank you very much. May I invite Palghar Academy of Pediatrics President Dr. Jayashree for vote of thanks. Jayashree ma'am. Dr. Neha, will you do the honors?
Yes, ma'am.
Yeah, please. It's time for vote of thanks.
So, on behalf of IP Raigad, IP Palghar, Maha AHA, and Raigad AHA, I would like to thank both our experts of today, Dr. Kranti Fadnavis ma'am and Dr. Amol Jayabhar sir, for wonderful talk on both the topics, which were very essential and very important for we pediatricians in our daily OPD. And I also thank Dr. Mahesh Mohite sir for giving his inputs and valuable suggestions. I thank Dr. Jayashree Deshpande ma'am, Dr. Ram Bharat sir, and Dr. Chitra Kulkarni ma'am, also Dr. Sangeeta Loda ma'am, for coming in our session, and thank all the attendees for joining today. Thank you.
Yeah, we could identify two senior pediatrician from Palghar, Dr. Suryakant Sankhe sir and Dr. Jagdish Bhatbade. Thanks for joining.
Thank you, sir.
Yeah, thank you, Dr. Vishal, for a nice support and live streaming of this event. Thank you very much.
Thank you.
Thank you,
so much.
everyone.
Thank you, everyone. Thank
Thank
you.
you very much. Thank you. Bye. Good night.
Thank you.
Good night.
Shall we stop the recording and we can end the meeting now?
Yes, ma'am.